in the room, she's not receiving any supplemental oxygen. Okay, so this is just kind of the base background, and so I make this go. So the idea here is that you have her heart, it's not getting enough oxygen to the tissue, and so you're seeing these changes on the EKG that's letting you know she could be having a heart attack shortly. You're just seeing the early signs of it, right? And so if you were a clinician instead of an engineer, the question is, what would you want to do? And the general idea is you would want to get more oxygen to that tissue so that she'll stop having these ischemic changes and stop progressing towards a heart attack. Okay. So in order to make this more of an engineering solving problem, I'm going to give you two choices. Okay. So the first choice is that you could give her some blood, and the blood would raise her hemoglobin from a hemoglobin of 7 to a hemoglobin of 9. We get, for an average size person, 1 unit of transfused blood raises the hemoglobin by 1 unit. Okay, so you go from about 7 to 9. And the other option is that you could give her oxygen by face mask, so that instead of breathing room air, and we'll pretend just for the sake of this problem, we're like in San Francisco at sea level instead of at altitude in Salt Lake here. But so we would go from an inspired oxygen of 0.21 on room air to 0.75 if you're giving supplemental oxygen. You can't really get 100% unless you have a breathing tube placed that's all sealed off. But so for the purpose of this problem, we'll just go to 75% oxygen. So before we begin on the discussion and the math, and I don't know exactly how to do this, maybe Rob can tell me, I just want to take a little poll. Who thinks that transfusing blood is a better option than giving the oxygen? And I'll assume those who don't vote feel that giving the oxygen is a better way than the blood. So I guess, I don't know if I can see everybody. Maybe, Rob, is there a way I can have people just raise their hand if they feel that giving the blood is the better option?
You can also do a yes/no question. So if each of the students click on the participants, and then Mark, you click on the manage participants, you'll see as each one clicks on either a green yes or a red circle no. You see Lars is green, Mark is green.
All right, so let's see. Oh, there we got. So I got 1, 2, 3, 4. Oh, now we're getting more votes. Well, there we go.
Sorry, which option is yes?
So yes is transfuse the blood. And if you don't vote or vote no, I'm going to default say that you're picking the supplemental oxygen. So we've got 1, 2, 3, 4, 5, 6. Nice. It's an even split. So we got 6 people who say give the blood, and that means the 5, I think, there's about 5 that are going to say give the oxygen. So that's good. That's an even split. Okay, so how should we approach the question? Before I proceed, I'm just curious kind of where we're at. Does anyone have an idea how you would figure this out as to which one is the better option? All right.
I thought it would make sense to give them blood because I thought their hemoglobin is low. So if their hemoglobin is low, even if you're giving them 100% FiO2, they still can't carry as much oxygen as they should because their hemoglobin is not where it should be.
Okay. I like that. I mean, in an ideal clinical world, we would probably do both, right? We would give them oxygen and we would give them hemoglobin, to your point. So obviously, the things you're sort of alluding to are, oxygen content. The hemoglobin primarily carries the oxygen. The other way that, you can get oxygen to tissue is the dissolved oxygen in the plasma. But as you're going to see as we go through this, the hemoglobin does carry a significantly more oxygen than the dissolved component in the plasma. And the other part of this is the whole story is not just how much is carried to the tissue, it's also how much the tissue can actually extract out of the blood, right? And you can't extract all of it out of the blood because a lot of it, still clings to the hemoglobin. So we're going to touch on that a little bit too. So those are kind of the two things you're thinking about as you're approaching that first question of which one is going to be more beneficial, even though in reality you're going to do both. Okay. All right. So this is a very general equation, thinking about tissue oxygen delivery and extraction. On the left-hand side, we have, it says CO, that stands for cardiac output. Okay, so how much is going round and round in the circulation? Okay, and then on to the right of the equal sign on the top, you have tissue oxygen extraction. That's how much the tissues are pulling out of the blood. And then in the denominator of that right side, you have the arterial content of oxygen and the venous content of oxygen. Okay, and so that's the general equation, that we use for calculating tissue oxygen extraction or oxygen delivery if you had a constant extraction, so on like that. Okay, and you can do it for the whole body, or you can do it across organs, right? You could do it across the brain, or a kidney, or the liver, or whatever. Okay. The other part we need to think about is how oxygen binds to hemoglobin. Okay. And so I have a picture up here of the oxygen dissociation curve. On the left-hand side, I have the percent of hemoglobin that's saturated with oxygen. And on the right-hand side, we have the partial pressure of oxygen. Being in the US, we still have not completely moved to the metric system in a lot of things that we do. So this is frequently given in millimeters of mercury or torr, and that's how it's labeled on the x-axis. And so, what you can see is as we go up in the partial pressure of oxygen, you kind of go up the curve and then it begins to flatten out right about after you clear 90. Obviously the curve's cut off, but it goes fairly flat after that point in time. Okay? And this curve is not completely fixed. Different things can move it, and they're listed on this graph here. So things that shift it to the right, increasing the temperature of the blood. There's a binding coefficient called 2,3-DPG, and also making the blood more acidic, shift it to the right, and that makes the hemoglobin want to give up oxygen at the same partial pressure. And you can also shift it to the left by doing the opposite of what's on the right. Okay. All right, now just as a sidelight here, because you may not just be engineering things for humans, this oxygen binding curve really varies among animals, right? And you can see the human there in the crosshairs, the red crosshairs, but the binding curve is very different for different animals. And even if you just think about mammals, it's still quite different. And so I bring this up, especially if you end up doing research on animals and you happen to be doing oxygen delivery and oxygen binding, make sure you don't use the human curve and just assume that it's, kind of static through evolution or across species. It definitely changes. So with that, we are just going to use the human curve for the purpose of this problem. So what we really want to calculate is what is the difference in the content between what's delivered, in this case to the heart, and what comes out of the heart after the myocardial tissue, the heart tissue, has extracted all the oxygen it can. And the heart right now, in the problem I'm giving you, is in a state where it is it is doing its best to extract every little molecule of oxygen because it's being starved of oxygen. And we know that from the changes in the EKG. So the first thing we have to do is calculate the content of the arterial blood going to the heart and the content of oxygen in the venous blood coming away from the heart. And I'm just curious, before I go to the next slide, does anyone know kind of the oxygen content equation that we use for blood? Okay, so this is the equation. And let's see, oh, let me go back. So this is content, and I didn't put the units on here, but we'll put them in here verbally. So the content in the arterial blood is mils of O2 per deciliter, right? Hemoglobin is in grams per deciliter. Saturation's just 1%. And partial pressure of oxygen is just in millimeters of mercury. That was my son in the background. Okay, so this is the equation that you use for calculating content of oxygen in the blood. So we're going to go through and put in some of those numbers. And so we put the hemoglobin of 7 in here. I told you that she was saturating 95% breathing room air. And if we go back to here, and you went up to 95%, we end up with a partial pressure of oxygen of about 85, which is how we got that 85. And so when you do the math, you get about 9.17 mils of O2 per deciliter of blood. Okay, that's what's coming into the heart, all right? And then the next question is, well, what's coming out of the heart? So there's a part of the heart called the coronary sinus, where after the arterial blood feeds the heart tissue and the oxygen is extracted from it, then the venous blood all flows into the coronary sinus before it goes out to the rest of the body and then gets reoxygenated through the lungs. And the question is, what is the baseline saturation in the coronary sinus? Okay. Now, I don't expect you to know that. So how did I come up with that? Well, I did what you would probably do if you were solving this problem on your own, is you'd go into the literature. And I happened to find some literature where they were doing cardiac catheterization. So they're putting a little catheter in the body and going up into those coronary arteries, and they were extracting blood and looking at the saturation of the venous blood after it had fed the heart tissue, and the saturation is 33%. So we are taking blood that's 95% saturated, it's feeding the cardiac tissue so it can beat and squeeze, and it's extracting all the way down to 33%. Okay? So if we go here and we look at 33% and we go over, we can drop down and see that it's probably around 23, 24 millimeters of mercury for partial pressure of oxygen. Okay? So if we look at the baseline venous content, some numbers stay the same, right? This fixed number stays the same. The hemoglobin is still 7, but now instead of a saturation of 95, we're down at 33, and the partial pressure of oxygen is down at 23 instead of 85. Okay, so this is the venous blood coming out of the heart, and so when we add those two together, we get 3.17, and then oh, my slides got messed up, but if we take 9.17 and then subtract 3.17 for the difference, it comes out to be 6, all right? So the difference between the arterial and the venous side is 6 milliliters of O2 per deciliter. All right, now let's go to the first choice, which is we're going to transfuse 2 units of red cells. Okay, so now is when I'm going to have you do this part of the problem since I took you through the baseline. Okay, so I told you 2 units of red cells will raise the hemoglobin by 2 points. And you can assume that the dissolved oxygen stays the same. Okay, so I'm just going to give you, we'll give you 2 minutes here to kind of plug that in yourself and calculate out the arterial content. Okay, I think most people are done. So we'll kind of put those numbers in, right? And so we put the 9 in for the hemoglobin instead of 7. This stays the same. So we get 11.46 plus the 0.26. So it goes up to 11.72, right? And then, oops, we can, rather than make you do the math again, we'll do the venous side of this. So we have the 9 in there again, and the 23, and we go down to 4.05. Okay, so the thing you should notice is, although we, definitely increased the arterial content, it went from 9.17 to 11.72. We also increased the venous content because it couldn't get all the oxygen off the hemoglobin. So that went from 3.17 up to 4.05. But overall, we did provide more extractable oxygen. So remember before the difference was 6. So now we're up to 7.67. And so we increased it by about 1.67 mils of O2 per deciliter. All right. So now let's see what happens if instead of giving more blood, we increase the inhaled oxygen. Okay. So the first thing we have to figure out is, all right, how can we calculate what oxygen is in the blood if we are increasing the oxygen that someone is breathing in the air? And then there's this item that's called an oxygen cascade, where you can kind of see the oxygen that's in the air you're breathing, and then the oxygen that makes it into the alveoli, the little sacs in your lungs that take up the air you're breathing. But not all of that is transferred 1-to-1 to the arterial blood. So that decreases it a little more, right? And then as it goes down into the organs, at the tissue level, It's even a little bit lower as it's sort of being extracted in the tissues. And then finally at the cellular level in the mitochondria, it's even lower. So you have this sort of cascade from atmospheric oxygen all the way to the mitochondria in the cells, right? And we are mainly working in this area here. And then we're looking at the extraction and looking at sort of venous levels as part of our equation, which usually mimic what's the tissue level. So the short story is, in order to calculate the arterial oxygen, we need to know what the alveolar oxygen is because it's very close to it, all right? And so there's an equation to do that, and this is called the alveolar gas equation. And so what you do is, based on the inspired oxygen you're breathing and the atmospheric pressure, you can calculate out the partial pressure of oxygen in the alveoli. All right? So let's kind of just go step by step through this. Now, if we were on room air, we would be breathing 21% oxygen. But remember, we increased the oxygen, and we're now breathing 0.75% oxygen here. All right? We're pretending we're at sea level, so we're at 760 for atmospheric pressure. If we wanted to do this realistically, Salt Lake, you're around 640 millimeters of mercury because of the altitude change. And then you also have the partial pressure of water that you have to subtract off. And you know, you can look that up in, I guess, steam tables and so on of your engineering books. But the partial pressure of water, vapor pressure of water, is temperature dependent. So we're going to assume that the patient is at normal temperature of 37. So the partial pressure of water is 47. And then the gas that's in the alveoli is not just oxygen and nitrogen. There's also CO2 in there that the person's making. So you have to subtract off the pressure from the CO2. And you do that with knowledge of what a typical partial pressure of CO2 is. That's about 40 millimeters of mercury. And then there's a fixed respiratory quotient we're using of 0.8. So if we plug all these numbers in, oh man, we have on this side of the equation 0.75 times the 760 minus 47. And then we have 40 millimeters of mercury for the partial pressure of CO2, and we're dividing it by 0.8. And it comes out to be about 484 millimeters of mercury, okay? And just to give you reference, if we had done this for room air, it will come out to be about 100 millimeters of mercury. So we've really increased the partial pressure of oxygen and the dissolved oxygen, all right? And the other part is, I'm not going to go through this equation, but there's a shunt equation so that you can calculate sort of what's in the alveoli, the little gas area of the lungs, versus what's in the blood. And without going through this, it decreases as you go from the alveoli in the lung to the partial pressure of oxygen in the blood. So we're going to go from 484 down to approximately 450, all right? Okay, so now back to our original baseline equation here. So to give you some numbers, the hemoglobin doesn't increase this time, right? It stays at 7. And I could flip all the way back to the oxygen dissociation curve, but remember I said it kind of leveled out after 90. Well, we're at 450. So we're at about 100% saturation on the hemoglobin. So that's going to be 1. And then I just showed you the partial pressure of oxygen. We were going to use 450, right? So I'm going to give you 1 minute to do one more equation. So plug the hemoglobin of 7 in, 100% saturation, and 450 into the partial pressure of dissolved oxygen. right. I think most people are done. So we'll do the math here on the slide. So now the bound component is 9.38 and the dissolved is 1.40. Now, to kind of put this in perspective, at the baseline before, this was 9.17, but we went from 95% to 100% saturated. So that went up just, around 5%. And then here we went from 0.26 up to 1.4. So we got a larger component from the dissolved oxygen when we're breathing these high levels of oxygen. And when we add them together, we get 10.78. Okay. So that's the arterial side. Now, the nice thing about dissolved oxygen is, unlike hemoglobin, you can use almost all of it, where the hemoglobin, remember, the heart could only extract down to 33% saturation. So when we're looking at the venous blood, here we have, again, hemoglobin of 7 extracting down to 33%. We have kind of the same numbers as before, but the nice thing is we went from 450 all the way down to 23. So we were able to extract a lot of that additional dissolved oxygen. And on the venous side, now we're down to 3.17. So on the next slide, the math I did is I said, okay, we have the arterial side, the venous side, and the difference is 7.61. And remember, at the baseline condition, it was 6. So we increased it with the oxygen 1.61. And so here's the results of the problem. So if we transfused 2 units of blood, we increased it to 1.67 additional mils of O2 per deciliter. And if we just added the oxygen, this should say 0.75, sorry, we got 1.61. So they're almost identical. And the reason I bring this up and the reason I chose to do this problem is because when people, I'm going to go back a few slides to illustrate this in that baseline condition, way back here. When people originally start thinking about oxygen delivery to tissue, they look at the components in the blood and they say, oh, well, all the oxygen is carried on the hemoglobin. So I'm going to ignore the right side of this equation, and I'm not even going to look at the dissolved oxygen, because they're saying, oh, I mean, we've almost got 9 there, and 0.26, I mean, that's irrelevant. But if you sit and you actually take this through the math, you start to see that the dissolved oxygen really does start to play a role when you're breathing more than room air. And you need to take it into account, because increasing someone just from breathing room air up to that higher inspired oxygen starts to make a difference. And the 2 reasons that occurs is because you have access to almost all that dissolved oxygen, where you only have access to about 2/3 of the bound oxygen on the hemoglobin. And to not confuse you, but to give you another point, the heart is probably the best organ at extracting oxygen. If we were talking about the brain, it can only extract down to about 55% on the hemoglobin. And most organs in the body, like the kidneys and the liver, are only going to extract down to about 60%. So you have even less oxygen that you can extract off of the hemoglobin, which then gives the dissolved oxygen a little more significance in the equations when you think about the extraction and not just the arterial content. So with that, it's basically a tie between the red blood cells and giving the additional oxygen. Okay, so before I go on to the second half of this lecture, I just want to know, are there questions about just general ways that we calculate oxygen content of blood, oxygen extraction in tissue, and so on?
Mark, I'm curious how sort of accurate or precise these numbers are and how much they vary from patient to patient.
Well, I mean, in general, I think the thing that's going to shift the most is that oxygen dissociation curve will shift a little bit, based on those elements, the acidity in the blood, the CO2 in the blood, the temperature of the patient a little bit, but that shift is probably only about less than 10%. And there are assumptions in this problem that I made. So I made the assumption that no matter which therapy we give, blood or oxygen, we're assuming the cardiac output is stable, right? It's not changing, because that is going to obviously affect the delivery substantially. And the other assumption I'm making is that because this heart in this scenario is so starved of oxygen, it's going to suck up all the extra oxygen that I give it, whether I give it dissolved oxygen more or I give it bound oxygen and hemoglobin. It's going to extract everything that it can because it's so oxygen starved. And obviously someone whose heart wasn't that way, the end venous blood coming out of the cardiac tissue would be different. So there are definitely a few assumptions in here being made, but in reality, we do see it clinically. If you have someone having myocardial ischemia or a heart attack, you do give them oxygen, and you can see things resolve from it. And similarly, if they're low on hemoglobin and you give them blood, that will also assist, and we do that also. So although there are assumptions, I don't think they're wildly out of line with most people.
Right. And then Mark had a question. Excuse me, Mark Fisher had a question. He can jump in if he wants to add more details. He just said, but why can the organs only remove oxygen to a certain percent?
Oh, that is an interesting question. I am going to be doing a little bit of hand waving, but I think it has to do partially with the oxygen dissociation curve and also the level of oxygen that the cells of that tissue can operate at. So if they can operate at a very low oxygen, then the cascade, you have a bigger gradient for more of the oxygen to come off of the hemoglobin. Whereas tissues that can't operate at low oxygen and don't normally do it, then you don't have as big a cascade. You'll see it a little bit here in the coming part of this lecture. I'm going to give you examples of what tissue levels of oxygen are in various organs, and you can see that they're not all the same. Right. So I guess to your question, it's a good one in that I don't want you to make the assumption like if you put an oxygen probe in the brain and the kidney and the heart and the liver, they're all going to be the same. They're actually all different because the cells operate at different oxygen levels. So I'm not pretending that fully answers your question, but those are probably two of the reasons that the extraction's different.
Yeah. Yeah, and ultimately, doesn't it come down to, you have a certain gradient of oxygen concentrations, and the flatter that gradient gets, the less transfer of oxygen actually ultimately happens. And so that's what, as you're saying, if the cells are operating at higher or lower levels, then the ambient oxygen concentration in those tissues may not be that different from what's in the blood once the blood has been partially decreased of oxygen. So it all comes down, I think, to gradients in the end. That's what drives all of these sort of ultimately diffusion type processes.
I think that's well put. The other reason I chose this problem, which I'll be interested, Rob, what you have to say, but it is often in a lot of high school physiology texts and even college level texts, stated it all just comes down to the hemoglobin, that the dissolved oxygen doesn't matter. And I use this example specifically so that you can see it actually does matter despite that general dogma out there, and you don't want to neglect half of the equation.
Yeah, no, I agree. That's a really good point.
All right, so with that, I'm not going to go too in depth on this. This is going to be a relatively superficial second half of the lecture. I just want to introduce you to different ways that oxygen can be measured in tissue. All right. So, We've talked a little bit about oxygen content, oxygen delivery, oxygen extraction, and ideally, we would like to move from measuring oxygen in the blood to measuring oxygen in the tissues themselves to potentially give us more information at a level of understanding so we know what's going on with the body, as opposed to just in general, this patient is low on oxygen. I'd rather know, are there problems getting oxygen to the kidneys or the heart or the brain or so on? And so the ability to, instead of just measuring oxygen in the blood, but measuring it in individual tissues, really increases our understanding of what's going on and could allow us to tailor a whole variety of medical therapies at an organ level. And when we're thinking about what would be an ideal way to measure tissue oxygen, we would obviously like it to be quantitative, to give us a very specific number. We would like it to be very minimally invasive, so we're not harming the tissue that we're trying to measure. We'd like it accurate over the entire physiologic range. We'd like to be able to repeat it at the same site so we could look at different therapies. And then something that, makes it beyond the lab or animal experiments and that is safe for use in humans. And, these are the things I'm thinking about when I'm thinking about different methods of measuring tissue oxygen. So one of the methods that is currently used and has been used for many, many years is a polarographic electrode. And what's happening here is you have an electrode which is placed on the skin, and you have to warm it a little bit. It's warmed actually to 44 degrees. And again, knowing that your core body temperature is 37, and skin is actually a little cooler. It's more like 35 in most people. And the reason you have to warm it up is there is a cutaneous layer in the skin that has to sort of be liquefied a bit for the oxygen to diffuse through it. And the idea is then you can look at the diffusion of oxygen from the capillaries in the skin or wherever this is placed, and they will eventually equilibrate with the electrode. And the idea is these capillaries are in equilibrium with the tissue that's surrounding them. Okay, so this method is used in medicine, and where we use it is often in determining, do we have enough oxygen around for successful wound healing? We know that oxygen is needed in wound healing for angiogenesis, for creation of collagen, so to make vessels, to actually create tissue, to prevent infection. And in general, we've found that unless, using this method, unless the skin tissue oxygen is above somewhere between 30, 35, you see a variety of numbers here in this column here, that if you were to amputate someone's leg, it wouldn't heal if the oxygen was below these values. So where an example of clinical use of this polarographic skin tissue electrode is in vascular surgery, where we will often go and measure oxygen of various parts of the limb in someone who is having trouble, say, with blood flow to their feet or toes. And we want to make sure if we amputate above that site that the tissue will heal and won't instead develop some sort of non-healing or infected wound. And so that's an example of where this type of oxygen measurement has been used. Another place the polarographic electrode has been used is in brain tissue oxygen monitoring. And this is often used in the neurointensive care unit or trauma victims where we're worried about, is the patient getting adequate blood flow to the brain Do we need to raise their blood pressure? Do we need to raise the oxygen that they're breathing to get more oxygen to the brain? Are they having too much pressure in their skull and we need to relieve it because that back pressure is preventing blood from flowing to the brain? And so one of the things that can be done is you drill a little hole through the skull and you place this electrode into the brain tissue, and it can give you a measure of tissue oxygen. Okay. Another way we can measure tissue oxygen is using an imaging technique, magnetic resonance imaging. And what we can do is put a tracer in there. An example is a fluorine-based MRI, and I'm going to keep it very superficial because I know my assumption is no one's had a lot of MRI in their bioengineering yet. But you can use magnetic resonance imaging to look at the relaxation of this molecule you introduce, this fluorine, and this relaxation rate varies linearly with the partial pressure of oxygen in the tissue. Now, again, you know, the downsides of that method before on the brain was that you had to put a probe in the brain. It's a little invasive, and you'd only use it in certain patients that, you know, weren't doing that well. Here, you have to inject a tracer into the tissue. This one is still only used in animals, and you have to have an MRI, right? But the interesting thing is it doesn't seem to be affected, its values aren't affected by pH, CO2, or very minimally by temperature. And you can see this really nice linear correlation between the partial pressure of oxygen and this MRI imaging relaxation rate in the graph there. There's a very minimal effect of temperature. And an example of this, I'd done experimentation in the past using this technique in some rats, where we went and anesthetized them, ventilated them through their trachea or windpipe, kept them at a constant temperature, were able to measure their hemoglobin, keep their lung CO2 constant because we were controlling the ventilation, and then give them either 30% oxygen or 100% oxygen to just look at the effect of increasing dissolved oxygen on their various organs. And then we would inject this tracer into each organ of interest and then take slices with the MRI, and the little colored portions are where the tracer was placed in each one of the organs. And then we would take an average of the pixels over each organ, and you can see, just like we kind of did in the equation, even though the hemoglobin stays constant, in these anesthetized, ventilated rats, that giving increased dissolved oxygen really did increase the tissue oxygen in each one of the organs. Again, it's not a perfect method because it's invasive. You're injecting a tracer in, you're traumatizing the tissue a little bit with the needle, but it is used for looking at various things. In this case, for artificial blood substitutes, it was used. There's another method called electron paramagnetic resonance. And here you use a solid tracer. You need a material that has an unpaired electron, and you place it into the tissue of interest. And then it interacts with the oxygen surrounding that tracer. And just like the MRI gives you a linear function versus the tissue partial pressure of oxygen. And we did a similar experiment using this technique. And you can see that there's differences in the partial pressure of oxygen in various organs in a rat. And in general, they all increase when you give more inspired oxygen and increase the dissolved oxygen. And then another method that is used for tissue oxygen, this one is not only used in animals, it is also now used in humans, is near infrared spectroscopy. And you have a light source that's shown through the skin, through the skull, and goes to the brain. And it has different absorption spectra based on whether it's encountering oxygenated hemoglobin or deoxygenated hemoglobin. And what they do with this is you have one portion of the light that goes deep and interacts with the brain, but you're obviously averaging everything that this light goes through. And then you have a superficial amount of light that ideally just goes through the skin and the scalp and the skull, and you end up subtracting off this from the deeper portion to ideally just give you what the capillary saturation is in the brain tissue itself. Okay, and so this is just the spectra of oxygenated or deoxygenated hemoglobin. Just so you can see, you would choose to look at wavelengths of light where they're different or where they're the same, and then subtract off differences between the two. And so those are four methods that are currently being used. Couple in, let's see, the transcutaneous, the polarigraphic electrode in the brain, and the near infrared are being used in humans, and the other two are currently just in animal studies. But it's a way of measuring oxygen in tissue instead of just what's in the blood. Okay. So one of the sort of thought questions I wanted to do with you in the, let's see how much time we have remaining, in the 15, 20 minutes remaining is, let's say that you wanted to set up an experiment to calibrate or test the accuracy, of a tissue oxygen device. And let's just use this device for the experiment, okay? So you've developed this device and you're shining light into what you think is the brain tissue, and you're ideally subtracting off the skull and the scalp and skin, and you want to know, is this thing accurate, right? What kind of an experiment would you set up to figure that out? I heard a chime. Did someone chime in? No.
And I assume this could be an animal preparation, correct?
Sure. I mean, we're going to do it in humans, and we did it in humans, but sure, you could start with animals. It's sometimes a lot easier because you can keep things more stable as to, how you would want them, or you can have more variance in humans sometimes. There's pros and cons. I mean, the pro of actually doing it in humans is you don't have to anesthetize them, right? They're going to take verbal commands, sit still, do what you want them to do, allow you to sample blood, put monitors on. Where animals, you have to anesthetize, and then that's going to perturb sort of the natural homeostasis. So, all right, well, we will kind of go forward here. So, what you ultimately want to do is you want to know as best as you can, what is the actual tissue oxygen, right? I mean, is there a way we can measure it? And nothing's going to be perfect. I mean, I guess one way is you could take one of these other devices that you consider a gold standard, like the polarigraphic electrode, and stick it in one side of the brain, and then on the other side you could go ahead and put the near infrared device on the other side of the brain, assume that they're similar, and then have the person breathe different partial pressures of oxygen or something like that. Another way to do it is to sample the blood. In this case, this polarigraphic electrode, this near infrared spectroscopy device, is actually measuring capillary blood. So one way to do it is say, okay, well, we know what the arterial blood is going into the tissue. And we can sample that in any artery. So we could go and sample that from, say, a radial artery in the arm or something, and sort of make a not invalid assumption that all the arterial blood before it actually gets into a given tissue is about the same level of oxygen. And then you could also say, well, I wonder what the venous side coming out of the brain is. And, you know, with anatomy, we know that there's 4 major vessels that provide venous drainage from the brain, but we could probably use one of the, you know, large neck vessels to sample the venous blood from. And we could make an assumption that the blood coming from a venous catheter snaked up towards the brain is probably similar to the other 3, you know, which is what was done. And then to look at the accuracy of the device, you want to perturb the system. So you want to have the patient breathe different levels of oxygen. You might want to change the amount of carbon dioxide, because that can change the blood flow to the brain and how fast it's flowing through. And then the other part is, I didn't tell you this, but when these devices were created, they make an assumption about the ratios of the oxygen in the arterial blood and the venous blood, like what portion of the brain is arterial blood and what portion of the capillaries is venous blood. And they make an assumption that those are set ratios. So if you applied those same ratios to your content equations for the arterial blood and the venous blood, you could then calculate out what the probe should be reading for the average between the two. And, you know, that's what's been done. So here we took this near-infrared spectroscopy device and put it on someone's forehead, or on multiple people's foreheads. And then we had them breathe in different amounts of oxygen and took arterial blood samples so we could measure the actual O2 in their arterial blood using a blood gas machine. And then to look at the effects of CO2, we just blended in different amounts of CO2 and measured it in their blood at what would be a normal CO2 and then a low CO2. And then we plotted those values of partial pressure of oxygen with what the device was doing. And then we did the calculations, kind of like we did earlier in this lecture, the difference between the arterial and venous blood, and using the set ratios that the manufacturer used, that 30% of the blood in the head should be arterial and 70% should be venous. And then we just took the difference between those two graphs to look at the accuracy of the device if we used the same assumptions that the manufacturer did. So it's a way of sort of using the equations that I showed you earlier on in the lecture, where you can actually calculate content based off of saturation and partial pressure, and then compare it to instruments that are being used to measure oxygen in the blood. So, I mean, I've kind of simplified that all, but, it's not, the logic is still there. If you know what's going into an organ and what's coming out and what the extraction is, and different components of arterial and venous blood, you could use that to calculate out how well your device is doing at measuring those components.
So I'll just butt in here. One of the questions Mark Fisher had, which I think is a good one, it sort of came up in Nathan Pace's talk yesterday a little bit too, is, how is this different and how is it the same from pulse oximetry? Because it looks like it has this, it's oxygenation, non-oxygenation, light, has a lot of the same elements, but what makes it different?
So what's different? So it's a great question. And I didn't originally, I could have covered pulse oximetry. But pulse oximetry, what it does is the device senses the change sort of in the blood volume by the absorbance of the light. And it knows when it's getting the arterial pulse and when it's not. And so what it does is it takes two measurements simultaneously. It takes what the sort of saturation is during the forward arterial flow when it's having more absorption from the increased blood. And then during the diastolic phase, when you don't have the forward flow, that's the sort of background venous blood that the light's going through, and it subtracts that off so that it's able to just give you what's in the arterial blood. The difference with this is the beam just goes through everything and there's no pulsation that it's looking at. So it's averaging together what's in the arterial blood and the venous blood and making an assumption about the ratios of the two and telling you that therefore that's approximately what's in equilibrium with the tissue, where pulse oximetry subtracts off that background and just gives you the arterial component.
Right.
It's a very general explanation, but that's sort of the difference between the two.
Yep, very good. And then I think it was Devin who asked, who asked the question about, excuse me, about fMRI and how, whether fMRI could sense flow variations in such a way that it could contribute to this or validate this.
Yeah, and I mean, you probably could. I have to think about that a little bit. I mean, you have some differences there where fMRI is flow in general. You can still get saturation off of, simultaneously. You could use another device and so on to do that. But I think you could do more of a correlation between fMRI and near infrared, but it would be difficult. You can't get the gold standard of actually calculating sort of the tissue oxygen level because the fMRI is more on flow,
Yeah,
right?
exactly.
But an example that you could do that would be very interesting, and I mean, there's more graphs here, but you could look at the effect of CO2 on blood flow in the brain. We do know that as someone holds their breath or their CO2 is increased because their ventilation isn't as good, the blood flow to their brain increases, right? And as the blood flow increases, you have less of a difference between the arterial blood going to the brain and the venous blood going out of the brain if you make the assumption that the brain extraction is constant. And so you might be able to correlate changes in flow from fMRI and changes in CO2 to what you're seeing on the near infrared device. So it's not measuring quite the same thing, but it'd be another way to potentially validate a portion of the device.
Right.
All right. Well, I finished a little bit ahead of time, a few minutes, but happy to take any other questions, but otherwise that's sort of the end of the material I wanted to cover.
So, Dr. Rollins, I have to preface my question by telling you that I am working on the kidney project with Kai Cook.
Oh, okay, yeah.
So my question is, are there any other surrogate measurements that can be used to estimate tissue oxygenation besides, for example, the urine oxygen tension? Is there something you can look at for other organs or that you know of, or is that not typically done?
Well, before I answer, can you, I mean, maybe all your colleagues know what you're doing, but can you just give a little 3 or 4 sentence explanation of the experiment you're doing with Kai Cook, and then I'll add to your question or answer your question.
Yeah, so we are using light as a source to possibly detect urine oxygen tension in urine as a surrogate for the tissue oxygenation in the kidney. And so the light shines on a piece of material, and that piece of material fluoresces, and then we measure the decay of that fluorescence, and using that we can determine the tissue oxygen or the partial pressure of the oxygen in the urine. And so hopefully we can measure that as a surrogate for what's actually going on in the kidney.
Okay, so you're using a quenching method is what's used at the tip of your probe. It has a certain amount of light, and then the oxygen interacts with it, and the more oxygen that's there, sort of the more quenching that occurs, and you get sort of a linear correlation with O2 and the output signal from your device. And
Yep.
the other part I would say, I know the device you're using, I didn't elaborate on it here, but it's very accurate at low levels of oxygen, things that are below 100. Which in most of the body in physiologic state is totally fine. If you were to have high levels of oxygen, like you're breathing supplemental oxygen and trying to measure things at high levels, the 300, 400, 500 range, it's all quenched, and then that device that you're using would become inaccurate. So part of this is, as just a side note, whatever device you use, you want to know the range that it's accurate in, as part of how you choose the device that you're going to use to measure a given tissue. Now, to go back to your original question, which was, so you are measuring oxygen in the urine, and the idea was that as the urine is passing through various tissues in the kidney, like the medulla and so on, it's equilibrating with the oxygen level in those tissues, and therefore, if you can measure the oxygen in the urine, it's a surrogate measure of what's happening at those tissues. And why would we care? The reason we would care is there are certain things that go on in healthcare where certain organs can become starved of oxygen. So an example that Kai and you are looking at, and you can correct me as I do this if I'm wrong, is sometimes when patients are having heart surgery, they have to go on bypass, where we take the heart offline and we use pumps to circulate blood in the body and take the place of the heart. And sometimes, even though we think we're doing a good job, we're not doing as good a job as the heart does. And we're not getting adequate oxygen to certain organs like the brain or like the kidney or so on. And if we could detect it early, maybe we could intervene and predict who's going to have kidney damage or change things to prevent the damage, right? Is that kind of accurate?
Yeah, no, that's right on.
Okay, so you're measuring oxygen in the urine, and I will say, when this project was started, I was curious but also very skeptical. I was wondering if the dissolved oxygen in the urine, by the time it got to your measuring device, would have already sort of begun to equilibrate across the tubes that it was being collected in, and you'd have a different oxygen value than what was actually going on in the kidney. And although you saw a little bit of that, right, you're kind of calculated it out through various mathematical equations looking at the urine flow. Is that true also?
Somewhat. Kind of where we're at currently, right? Is we realize facing the oxygen diffusion leak. So oxygen is diffusing in and out of the urine as it goes through the different pathways until it reaches our device.
Right.
So that's kind of, what we noticed from our data. And I think that's kind of the next step in the development of our device, is saying, okay, what are the equations? And if we use these equations, can we backtrack to say this is what it was in the kidney? Because we have the urine flow measurement, right? Because if you didn't have flow, that would be hopeless. But anyways.
So now, ideally, I do believe an experiment that would probably be beneficial is to now go out of humans and go into an animal model and have the exact same setup you do, and be able to perturb their blood flow to the kidneys to make the kidneys hypoxic, or some gradation of that. And I would take a polarographic electrode and I would stick it in the medulla of the kidney. And then you could correlate what's happening in the urine oxygen with the gold standard of what is happening in the medullary tissue of the kidney at that time. And I think that would help your model out a lot, as far as, what's happening to the urine between the medulla and when you're actually measuring it, and being able to correlate with the amount of urine that's being produced. So that's one thing I think, I might do, and you could choose what animal model would, pig or sheep or whatever, something sort of the same size as a human, just so you didn't have to go so small for rats. But that's one thing I would think of doing.
So that's actually interesting. That's kind of what we've talked about doing next. And then that the DoD grant, we're in the process of putting together a DoD grant for just doing exactly that, except for instead of a polargraphic electrode, we've talked about measuring it in the renal pelvis, because there's enough literature to say the oxygen of the urine in the renal pelvis is representative of what's going on in the kidney tissue. And we've talked about possibly doing a polargraphic electrode, but the issue is hemorrhaging, and you get clotting around the electrode that can interfere with your measurement. So there's some discussion about what exactly we're going to do, but.
Well, I mean, I still think, the tools exist. You can borrow, I have some polargraphic electrodes, but despite the little hemorrhage around the electrode, it might be worth it to do both. Do exactly what you're saying, but also stick the electrode in a different part of the kidney, or something else. It's just something to think about. But kind of the point of the second half of this lecture is there's no measurement that's ideal. Everything sort of either perturbs the system or has assumptions, that it's based on in get at what it's actually measuring. But great question and great example to tie in with this lecture.
Okay, if there are no more questions, let's go to our menus and find our little hand clap glyph there under the More button, and thank Dr. Rollins for a great presentation. And I'm already setting up with another one of his colleagues, Harriet Hopf, next week, and she'll talk, I think, a lot more about oxygen delivery in a specific context of wound healing. So the two
There
lectures.
will be overlap. I studied with Dr. Hoff for many years, so there will probably be overlap in our lectures.
Yeah,
but maybe not too much.
Yeah, but I'm sure she'll focus much more on the wound healing and all the aspects of that. So they should complement each other really well.
Good.
Great. So thanks everyone, and we'll see you all next week.
All right.
Thank you.
Thanks for your attention.
Yeah,
Thank
thanks,
you.
Mark,
Thanks.
for this.
Thank you.
Bye.
Great.